Kidney Cancer 101, kind of like we're back in school here in that entry level class. We're going to start at the 30,000 view here of kidney cancer, and that's epidemiology, really the study of the population and the population of patients with kidney cancer. And it's a little bit small. I'm sorry, you can all move up to the front row if you want, but basically you can tell from this on the male side and the female side kidney cancer is not the most common cancer. It's not actually a rare cancer. It's kind of in between. And that's good and bad. We have some numbers to study, but maybe not enough. And it's, as we'll see, not one disease, but it's also different in men and women. Men have about 2 times the rate of developing kidney cancer as women. What's interesting is that that's probably right up through menopause, and then the rates kind of even out. So there probably is something hormonal related to kidney cancer as well. But be that as it may, we do see differences here, and there may be differences in the biology in patients, because of gender. It's still probably not really understood enough to change our therapy, but could be in the future. There are other risk factors besides gender associated with kidney cancer, and those include smoking, obesity. We have body mass index there for the scale, blood pressure, and elevated blood pressure increasing the risk. You can see over on the other side are genetics and the different genes and mutations that can happen in kidney cancer. And different types of kidney cancer have different types of genetic alterations. And then there are some forms of kidney cancer that are inherited from the genes you inherited from your parents and that mix. And there are some families in which kidney cancer runs, and it tends to happen at a younger age with multiple kidney tumors. So just know that, this is not a, kind of one size fits all monolithic disease. And some of these risk factors really matter. One risk factor not on here that's, I think, really important is geography. When we look across the United States, the rates of kidney cancer are not the same in every area. In fact, when you look in Louisiana and Texas and Alaska and maybe the Dakotas, the rates of kidney cancer are much higher. The rates of death from kidney cancer are much higher. And the reason is probably environmental factors. There's a lot of oil and gas that is being drilled and other things and processed in those areas. And there very well may be environmental factors that also play in. And they're not the same for every cancer, but for kidney cancer, those are the areas we see the highest rates. Thankfully, we don't have that in North Carolina. We're pretty good here. We're kind of middle of the road. So that's one thing we have going for us. Again, sorry about the size of slides. It looked good on the computer. If anybody wants to come up here, you can read it easily. But familial kidney cancers, I mentioned that genetic piece there. There are a number of genetic familial conditions that lead to kidney cancer and different types of kidney cancer. And we don't have to get into the details of these. Thankfully, they're rare, but importantly, they're different, and they give us an opportunity to intervene early in this disease. So I'll just point out the top one, which you can't read, but it says von Hippel-Lindau. Now, that's actually German for VHL. No, we just call it VHL because it's easier. But VHL syndrome is a condition that's inherited and puts you at risk for a number of sort of mostly non-metastasizing tumors, but kidney cancer is one of the ones that it's associated with that does spread. And these patients develop kidney cancers in their 20s and 30s and 40s, and sometimes scores of kidney tumors. And what's changed in the field is ability to treat these patients when these tumors are very, very small, because these patients used to die of either metastatic kidney cancer or kidney failure because we couldn't protect the kidneys. And now we're changing that disease at the early stages. So our hope is we're going to be able to do that for other forms of kidney cancer. And this is where research is so important because none of those advances happen without research. For those of you have maybe not looked at your images, shame on your physicians for not showing them, but it's important, for people who are, interested to kind of know a little bit what your tumor looks like. This is a tumor in a kidney, and imaging is a really important part of how we diagnose and follow and even treat kidney cancers. And it's important, you'll hear a little bit more about this, but it's important because kidney cancer has some really distinguishing features to it. And one of the things you can see, it's got some whiteness to it. That's the IV contrast. And it's particularly IV contrast that can be seen very early in what we call the arterial phase. So kidney cancer has some very unique features to it. Tends to grow out of the kidney. You can kind of see it like this kind of softball growing out of the kidney. And sometimes that makes it very amenable to localized treatment, partial resections, radiation, or even ablation techniques. And you're going to hear from speakers today about each of those kinds of approaches. So kind of understand a little bit how there's multiple ways to treat kidney cancer, and we use them all at places like Duke and UNC. And you'll hear from our tumor board discussions here, our panel, a little bit how maybe we make those decisions. I mentioned earlier, kidney cancer comes in different flavors and types. These are the three most common and this is what our pathologists look at. So when you have your kidney cancer biopsied or resected, they're going to cut it into slices, kind of like prosciutto, really thin, and then they're going to put it on a glass plate, and they're going to put sauce on that prosciutto so we can see this. We call it a stain, but it's purposeful stain. And we do that so we can see the cells within that tissue, and they look different. And you all don't recognize these different things, but you can see from this view that they're all very different. And the one in your upper left, that's the clear cell. And it's called that because the cells, if we zoom in on them, are mostly clear in the center. It's got glycogen, kind of a sugar deposits in there. And it's got a really tight little black hole called the nucleus, very tight nucleus and nuclei, and then a rim around it. And then you'll see some of these strands across. That's some of the connective tissue that helps hold that tumor together. And that's kind of a classic, what we call well differentiated. It looks a lot like what I described. Some of them will look more aggressive and less like that. On the other side is papillary renal cell carcinoma, and that's one that forms almost like broccoli, these large nests on the top and stalks. And we're cutting a cross section of this, so it kind of looks a little bit like a floodplain, like rivers that have flooded over. But that's some of this papillary structure associated with it. And on the bottom is chromophobe, which we are beginning to appreciate more and more as an entity in and of itself. Sometimes we consider clear cell the most common, the only type of kidney cancer, and develop treatments for it. More and more, we're developing treatments for papillary cancer. It's about 15%, and chromophobe, which is just 5% of kidney cancers, but it's important, distinct biology associated with it. And it's got a different picture. Believe it or not, there's like 17 other forms of kidney cancer. We're not going to go through them all. They're rare, but they're distinct. And we don't do this just for, academic purposes. These are different biologies. And someday we're going to have treatments specific to these other rare forms. But this is what it looks like when it comes out of your body. This is actual tumor, and this is an aggressive one. In it, there's some of these pale areas that kind of look yellow. And what that is necrosis. Nice Latin word for dead tissue. And it's essentially has no blood supply. So that's why it looks so yellow like that. It doesn't have any blood flow. The rest of the tumor looks very bloody, looks highly perfused. And there's a little asterisk in there. It's actually not part of the tumor. They put that on the slide, and it's just pointing us to where this sarcomatoid features are, and there's a little bit more aggressive features. Again, hard to appreciate it here, except to say that this doesn't look the same all the way through. A kidney tumor has, even within a single tumor, lots of different pieces to it. And our pathologists do a great job of describing all of that to us. And it's important. It holds some weight in terms of the likelihood of your disease spreading or coming back. And that's what we call your prognosis, your risk of disease, occurring and spreading, or you even dying of the cancer. And it's important to know that it's a statistic, and you all are not statistics, you're individual people, but statistics help us in understanding how we're going to manage you. The other thing that's really important on kidney cancer, besides what I showed you, those different compartments and features of the cancer and what we call sometimes the grade of the cancer, is the stage of the cancer. This is how far the cancer has progressed. And it's really important because, like grade, stage has a lot of prognosis and a lot of weight in terms of the likelihood that you might have disease that comes back or spreads, or maybe is already spread. Stage one means it's contained within the kidney and it's less than 7 centimeters. That's kind of big. If you had a 7 centimeter prostate cancer, you would definitely feel that. It would be hard to walk. If in kidney cancer, because of where it's located, you might not feel it at all. And it's stage one because it's a good prognosis. A 7 centimeter breast cancer almost certainly has a high risk of spreading, but a 7 centimeter kidney cancer really doesn't. And so it's important to recognize that stage is different for different cancers. In kidney cancer, we're lucky it doesn't spread very early, very often. It can, but it usually doesn't. Stage two is bigger, above 7 centimeters, but still contained in the kidney. Stage three means it's gotten through the capsule, this nice wrapping around the kidney. We have it kind of showed, not the dotted line, but the line underneath the dotted line. And then you see the dotted line is something called Girota's fascia. Kind of like, I mean, I'm not sure who Girota was. I think he might have been in Star Wars, but I'm not sure. But Girota, I first identified this fascia, so he gets the name. I'm assuming it's a he, probably because it's old. But it's an important layer because when the cancer grows beyond that, it's now what we call stage four. It's really into other tissues and stuff. So you can see down there that stage four kind of beyond that can be into lymph nodes. It can be into, beyond stage three is within that Girota's fascia. Stage four is outside of it, or if there's distant spread, is stage four. So those are stages. Over there, you can kind of see the pie chart of what the frequency of these different stages are. And then on the far end, you see the prognosis, the 5-year survival associated with these different stages. And I can't see it from where I am, but it looks like stage four is the lowest there. So just so something, yeah, 20%. So, some of that is older data. I will tell you that I think we've really made a tremendous amount of progress in kidney cancer. And even if you think about what the progress we've made in the last 5 years, that's not showing up in our statistics because those people haven't lived 5 years yet. So I think for the good news is we've really changed the outlook of this disease, and stage isn't the be all end all anymore. For those patients with metastatic disease, we use other factors to help prognosticate, and this is one of the older ones. These are the two terms. These are the factors your doctor is going to be measuring in you. Your performance test is how much you're functional each day, if you're able to do your normal activities. For men, that's watching TV and maybe getting the mail. For women, that's like all the chores and everything. No, truth is like you got to be like active, like you can, work and exercise and do all the things you need to do for for that. And then we if you're above 80% of that, and there's a different scale I won't go into. How long it takes your cancer to spread, whether it was there from the beginning or not, is important. And then some of these other factors here that are measured in the blood. And that gives us a tool, a multifactorial tool to help figure out where you are in terms of your prognosis. And even this is dated. even this has changed. Immunotherapy has changed our prognostic tools and turned them on their heads. And some of the best benefits to immunotherapy are in our worst prognosis patients. And so, even the things you may hear on the internet or read on the internet or see on the internet may be based on old data. And it's really important because people are going to the internet more and more now with IO and things like that. We can talk a little bit about it because where that information is coming from could influence, that information and maybe give you a false sense, either good or bad, of what your situation is. So it's really, really important. I'm not discouraging people from reading or getting information. Just talk to your physicians about it. Talk to your, healthcare providers. Use resources like the KCA because it's a great way to really validate what you might be reading. We're going to go into how we manage kidney cancer. We're not covering it in this talk, but you're going to hear about a lot of these things I've already mentioned about surgery ablation. You're going to hear about immunotherapy and targeted therapy in our patients with newly diagnosed metastatic cancer, as well as in these kind of situations where the disease has progressed through one line of therapy, what we might call refractory kidney cancer. It's not refractory, it just means it's been treated and it's going to need new, maybe different treatment. But we have a lot of things, radiation, and even maybe some newer forms. These are some of the different treatments that we'll cover. And just to show you ablation, there's different types of ablation, and you're going to hear a lot about how those are used, the pros and cons of different ones. Radiation, there's different ways of giving radiation, and you're going to hear a lot about that. And then that's surgery up there. There's no robot, but there probably is now, but that's how we used to do surgery, touching patients. And there's still a role for surgery even in our metastatic patients. And we do, historically some of that, I would say even more so today. Some of the treatment outcomes for the spread, you'll hear about how we treat localized cancer, but you'll also see how we treat metastatic cancer and how we blend the two. And we'll again have some panels discuss about that. And then you'll also hear a talk on living with one kidney. Many of you have had surgery or treatment on your one kidney, and you have one remaining. And everyone says that's great. That's why God gave us two kidneys. But the truth is that, it's different having one kidney. You're at risk for certain complications that with two kidneys, you're a little bit more protected from. And you'll hear from one of our physicians about how, a nephrologist in particular, about how we manage that and some of the things you can do to help protect your one kidney status and make sure you can live a full life with that. And then lastly, the KCA. And this is, Kendall mentioned this at the beginning. This is a great resource. I'm part of the KCA, full disclosure. I'm on the board and the medical steering committee, but it's a great organization. I lean on it a lot. A lot of my colleagues do. We have some great meetings and would encourage you all to sign up and be part of it. It's free. It's a great resource and community.